Well, it is my pleasure to give this lecture here today, although I had to travel far, not that far. Squamous lung cancer. I think I need to figure out how to advance my slides. Here, I got it. I will try to be fast because I put a lot into this lecture, so I'm going to do the historical perspective relatively fast. The slides are there, so you can refer to them, and then I'm going to stay a little bit longer into the new developments for this disease. So as you know, there is a clear distinction in terms of histological features between adenocarcinoma and squamous cell cancer, and these are the most common things our pathologists tell us when we get that specimen analyzed. So we get CK7 positive, CK20 negative, TTF1 positivity for adenocarcinoma, and then for squamous cell carcinoma, we're looking at morphology, of course. But then we're also looking at the markers. CK7 and CK20 are usually negative, TTF1 is negative, and then we get P63 and P40 positivity. These tumors are the other cancers, as Corey said. They're distinct in their presentation, that they usually have a more central presentation, and they have a rare metastatic spread up front. But they do spread, and they do have metastatic presentations occasionally. It is declining in incidence here in the US and in other countries, but it's still going strong in Eastern European countries. It's a smoker's disease, and the mutational profile suggests that very strongly. So, historical perspective, bevacizumab was the first targeted agent that was actually excluded from further consideration of squamous lung cancer. Why? Because in the first phase 2 trial, there were episodes of pulmonary hemorrhage, and the majority of these episodes occurred in squamous cell lung cancer. Therefore, we eliminated further study of anti-angiogenic agents for a long time, until relatively recently. So what is standard of care still for squamous lung cancer? It is chemotherapy. And I'm going to go rapidly through the different trials that have looked at that. So we can use a combination of platinum, or that being cisplatin or carboplatin, with gemcitabine. Taxanes are also very frequently used, and this data with nab-paclitaxel from 2010 established the use of nab-paclitaxel in this setting as well. And there was obviously a benefit that was demonstrated for squamous cell histology in this data. The primary endpoint of this clinical trial was a response rate, and you can see that there was a clear benefit to patients with squamous cell lung cancer in the right side panel. No difference, a significant difference in terms of progression-free survival, although numerically superior for nab-paclitaxel, and then overall survival, similar trend. There was a benefit for patients over the age of 70, and therefore there is a lot of study, and I'm going to skip these slides very fast, in second-line therapy in maintenance and for elderly patients. How about EGFR alterations? I have 2 chapters of EGFR alterations in this talk. One is pertaining to the antibodies, and I'm going to go shortly into that, and the other to EGFR TKIs. We know that sensitizing mutations in the EGFR are exceedingly rare for squamous cell lung cancer. We occasionally see them, especially now that we're doing liquid biopsies in tumors, but frequently that is because those are mixed histology tumors. So very rarely do we see the classic sensitizing mutations to EGFR TKIs. But we do see amplification. 7 to 10% of squamous lung cancers are amplified, and we do see increased expression by immunohistochemistry. And these were the premises on which a series of clinical trials were performed. And I'm going to show the studies with cetuximab and necitumumab here. So FLEX was the first of these studies, combination of cetuximab with a backbone of vinorelbine and cisplatin. There was a modest benefit in terms of overall survival in the overall population that was demonstrated. and there was a superiority in terms of both response rate and progression-free survival was equal in both arms. There was a predefined subset analysis in Caucasians that demonstrated an even larger benefit with a hazard ratio of 0.8. And then in subgroup analysis, as you can see here, there is a clear benefit in patients with squamous cell histologies, and even more so, the benefit is magnified for patients with a positive H score. So squamous histology, positive expression, there is benefit from these antibodies. And this is shown here as well in this slide, so I'm not going to belabor the point. The second study that studied this combination with a backbone of taxane and carboplatin is BMS 099. Similarly, a modest but present benefit for the combination of cetuximab with chemotherapy. SWOG 0819 was reported 2 years ago and investigated the question of adding cetuximab to a backbone of bevacizumab in bevacizumab-appropriate populations and cetuximab alone in the non-bevacizumab-appropriate populations. And this was based on prior clinical trials piloted at SWOG 0536. The bottom line is that this study was looking at progression-free survival in EGFR FISH positive patients. So for EGFR positivity, the definition here was made by FISH, not immunohistochemistry, and overall survival in the entire population. There were a number of secondary endpoints, including one that was added and pre-specified before the analysis, which included analysis of the overall survival in the entire study in FISH-positive squamous cell patients based on the prior data. Here is the Colorado definition of FISH positivity for EGFR. Again, I'm not going to go over all the points. I think you've seen this before. And here are the results. So for the entire population, overall survival was completely identical for the two arms, as was progression-free survival. But when you did the subset analysis for FISH-positive patients, there was a trend for benefit in overall survival. And this benefit was magnified in the bevacizumab-inappropriate patients, especially the FISH-positive ones, where the hazard ratio went down to 0.75. Squamous cell histology also clearly benefits from this combination, and especially in the FISH-positive subset. The SQUIRE study with necitumumab, another antibody against the epidermal growth factor receptor and a backbone of gemcitabine and cisplatin, demonstrated that there was benefit in terms of overall survival as well, modest benefit, but a hazard ratio of 0.84. And in the copy number gain subset, the benefit again was larger. So in conclusion, what do we do with these antibodies here? Do we use them or not? So necitumumab is FDA approved. Cetuximab is not FDA approved. The adoption has been limited because of the modest improvement in overall survival. And there is a need for maintenance necitumumab if you're going to use it. And there is toxicity associated with this combination. So checkpoint inhibitors have emerged over the last 2 years, 3 years, and I think they're displacing consideration of these antibodies, but they're available to us and they can be used in the right subset of patients. How about immunotherapy? So I don't know how many of you were at ESMO 2016, but there is before and after ESMO 2016 this year because there were many important presentations at the meeting. So this is the landscape pre-ESMO 2016, and there were a number of checkpoints that we looked at in the first line, all generated tons of enthusiasm because single-agent activity is associated with a high response rate, and this high response rate is even higher in PD-L1 positive patients, and you can see it stands out, and I don't know if I have a pointer here. Maybe I don't have a pointer, but you know, it goes as high as 58% for more than 50% expression for the pembrolizumab studies. So there was a lot of hope for first-line use of these agents as single therapy in patients with previously untreated non-small cell lung cancer, and compared with chemotherapy, and a number of studies were performed in that regard. So Checkmate 026 was reported at ESMO 2016. This was a clean randomized study of nivolumab versus chemotherapy with a maximum of 6 cycles, and the primary endpoint was progression-free survival. Crossover was allowed, it was not prohibited, to nivolumab at progression for patients with chemotherapy. There were a number of stratification factors at randomization, and these are shown on the slide. PD-L1 expression less than 5% and more than 5%, and histology squamous versus non-squamous. Secondary endpoints were progression-free survival in the more than 1% PD-L1 expression subset, and overall survival as well as response rate. Everybody was very disappointed to see this result here. So progression-free survival was inferior for nivolumab numerically, 4.2 months versus chemotherapy, 5.9 months. 1 year progression-free survival was 23.6 months and 23.2 for chemotherapy. So the hazard ratio across unity is 1.15. And here is the subset that is of highest interest, the high expressors, more than 5% PD-L1 expression. And here, nivolumab is performing a little better than chemotherapy, but still the hazard ratio remains at 1.02. So the summary of the responses in more than 5% shows that nivolumab looks inferior to chemotherapy, particularly in this group of patients, with a response rate of 26% and 27% of the population progressing, actually, while chemotherapy is associated with, one would say, a rather high response rate for our standard criteria, 33%, and 9% of the patients progressed. In squamous population, though, the benefit is still there, and this was shown in subset analysis in the forest plot. So the hazard ratio in this otherwise negative study for squamous patients, squamous lung cancer patients, was 0.83 for progression-free survival and 0.82 for overall survival, suggesting benefit in this group of patients. The diametric opposite results from disappointment to great enthusiasm was Keynote 024 study, and the key eligibility criteria here obviously played a big role in the success of this study. So patients were eligible only if they had expression more than 50% in their tumor of PD-L1, and there was again a clean randomization between standard pembrolizumab schedule and chemotherapy. 30% of our population, or at least the population that was screened in this trial, but this is consistent among other observations from other studies, is belonging to this high expression group, so 1/3 of our patients. And here is a tremendous success of this study. Progression-free survival was clearly superior for pembrolizumab in this highly selected group, with a hazard ratio of 0.5. And the benefit actually increases over time. So at 6 months, there is a difference of 62 over 50% for chemotherapy, and this is magnified to 48 versus 15% at 12 months. Overall survival, again, the median is not reported here, it is too early, but the hazard ratio is 0.6, so this study won on both fronts. So this defines obviously a new standard of care for both histologies, squamous and non-squamous, for patients with high expression, more than 50% PD-L1. And I want to show this data here, not because it's Corey's data, but but because it is important to remember that the combination of chemotherapy with immunotherapy is being explored, and we have early positive results for this combination, albeit in adenocarcinoma. So this is not really pertaining to our squamous discussion. These were presented by Corey, and I'm sure they're going to be presented during the meeting, so I'm not going to go through this data. I'm going to skip these slides, which gains me a lot of time, to say that the other big area of exploration, as was previously alluded by the speaker on mesothelioma, is combination immunotherapy with anti-CTLA-4 and anti-PD-1. Nivolumab and ipilimumab is one of these combos. Very encouraging results in frontline therapy. We're eagerly awaiting the results of clinical trials that will demonstrate whether there is benefit or not against standard of care in frontline. So in second line, again, I have to go fast. We have 3 approvals in this setting. Checkmate 017 established the superiority of nivolumab over docetaxel, and Keynote 010, the superiority of pembrolizumab over docetaxel. Especially important here is to remember that the threshold for benefit doesn't start at 50%, it starts at 1% expression. And the value of PD-L1 by histology in the squamous group appears to be a little lesser than in non-squamous. So you can see that the benefit extends even to patients that have low PD-L1 expression. Again, this is a discussion that shouldn't be had here, but how we measure PD-L1 expression is a problem in the community, and we know there is discordance between the antibodies. The clear winner at the moment is obviously the antibody that is associated with the standard of care new therapy in frontline, but I don't need to belabor the point that we have several ways to measure PD-L1, and they're not all the same. Atezolizumab was also recently approved by the FDA based on the results of the OAK study, and this study demonstrated the superiority over docetaxel. You can see the results here, and important to say that PD-L1 expression also made a difference here, but overall, if you combine all this group, even the group that has no expression receives benefit from this drug. Therefore, the label does not include selection by PD-L1. So the conclusions here is that we have a major change in landscape for frontline therapy of non-small cell lung cancer, including squamous lung cancer, and for second-line therapy, PD-L1 selection may take second place to convenience. Both nivolumab and atezolizumab are approved without a positive label. We need to further investigate combinations. How about genomics and biomarker-driven clinical trials? I'm so glad Shakun Malik gave you the lecture this morning because I have very few points to make on top of what she made. But in any case, TCGA told us what the molecular landscape for squamous and non-squamous lung cancer is. We have this information for over 4 years now, and this has changed how we think about this disease. We used to think about this disease as a responsive to chemotherapy, marginally, molecularly selected disease. But there are drivers for squamous lung cancer. Unfortunately, these drivers are buried between a ton of mutations, and it's hard to distinguish what is a driver and what is not in this disease. We have selected a number of these for therapeutic target development, and those are the clinical trials in summary that have demonstrated modest activity against FGFR amplified tumors with the 2 agents, AZD4547 and BGJ398. We have also seen negative results with PKM120, which was a PI3 kinase targeted agent that was closed. There is still an ongoing clinical trial as part of LungMap with JDC032. We have also examined agents targeted against DDR2, and this study early results suggested that there is activity with the combination of dasatinib and erlotinib. But here is the bottom line. It's very hard to do these studies in rare populations. Standalone clinical trials are not feasible. They usually close for low accrual, or even if you achieve your accrual, selection may become very significant here. So because of this, we thought 3 years ago that it was time to have a different approach for squamous lung cancer as we have had for adenocarcinoma for years, and we designed the squamous lung master protocol. Initially, it was a randomized approach against standard chemotherapy. As you all know, this changed over time because we had approvals with nivolumab. The basic principle of this clinical trial is that all patients are profiled up front and assigned to clinical trials with targeted therapy of choice, if there is a trial in the umbrella, or they go into a non-match arm, which these days is immunotherapy. I'm going to skip here to say that we had, up until recently, 3 trials that were open in the matched category with palbociclib, AZD4547, JDC032. The studies are single agent now, hoping for a high threshold response rate to proceed to randomization. So if the studies fail to demonstrate that, they're closed and substituted. Our non-matched sub-study at the moment is a checkpoint naive study with combination of nivolumab and ipilimumab against nivolumab. These studies are closing and are being replaced by a new sub-study for homologous recombination deficient tumors with PARP inhibitor, talazoparib, and then we will expand the checkpoint refractory arms with more combinations. You're seeing one here. I'm going to skip the last few slides because I'm over time. Those slides were meant to discuss the use of EGFR TKIs in squamous lung cancer. I'm not going to say too much. You all know that the label for Tarceva eliminated squamous lung cancer at this point. And the LUX-Lung 8 data that I was planning to show were a randomization of afatinib against erlotinib, showing superiority for afatinib. Afatinib is still an option for these patients, but I don't believe too many people will be using afatinib in second line or third line. However, this option is still available for us. The only other thing that I think it's important for us to remember is that after years, so I'm skipping this slide, after years of bevacizumab exclusion, ramucirumab emerged as an agent that may be useful for all histologists, including squamous cell lung cancer. This is the REVEL trial design, and this is the bottom line here. There was a benefit for overall survival and progression-free survival, and this was irrespective of histology. Both squamous and non-squamous patients benefited from this combination. So this is the first angiogenesis inhibitor that is approved in squamous lung cancer. It has not been extensively adopted, and it has not been used as a control arm for many studies. However, it's an option that is available. And it is an option that should rationally combine with immunotherapy because of the reasons that were explained in the prior talk. So I arrived to my overall conclusions. Immunotherapy is moving to the frontline space for PD-L1 overexpressing tumors. Combinations of immunotherapy and chemotherapy are promising, and they should be further explored. Results of combination immunotherapy trials in the frontline are eagerly awaited by all of us. Combination chemotherapy remains the standard of care, though, for PD-L1 negative patients, and we should maybe consider the addition of necitumumab for EGFR FISH positives. Immunotherapy is the clear standard of care in second-line therapy for all patients with squamous lung cancer, and we have several options: nivolumab, pembrolizumab, and atezolizumab. And with this, I thank you.